Hello, I'm Dr. Hagop Kantarjian from the Leukemia Department at MD Anderson Cancer Center, and it is my honor and pleasure to interview Dr. Nicholas Short from the Leukemia Department at MD Anderson. So let's talk about older patients with pre-BALL. So these patients do not tolerate intensive chemotherapy. What are we doing to improve their outcome with some of the newer modalities?
Yeah, so as you mentioned, historically, if you gave them intensive chemotherapy, patients over 60 years of age, even dose-adjusted chemotherapy for the age, you still saw 5-year survival rates of around 20%. And then if you reduced the chemotherapy too much, it was really an exercise in futility. These patients didn't respond or they didn't have durable remissions. So we're really stuck until the new era where we had drugs like inotuzumab and blinatumomab bringing them into the frontline setting. So I think things have really changed with the development of these drugs, approved initially in the relapsed refractory setting, but then evaluated in clinical trials in the frontline setting across the board, but particularly in older adults, where we've seen actually the greatest improvement in outcomes as we've moved to these novel immune therapy-based approaches. So, at MD Anderson, we started doing mini hyper-CVD, so a low-dose chemotherapy regimen initially with inotuzumab. Then later that was amended to then add blinatumomab, so mini CVD in Oblina. And then in the most recent iteration, we do it in a dose-dense fashion. So we give all of the drugs even in cycle 1, so low-dose chemotherapy along with inotuzumab, and then as soon as the chemo finishes, we start the blinatumomab to try to get the deepest response as quickly as possible, which we know is associated with better outcomes. And with this, we've seen tremendous improvement in the outcomes for these patients with older patients with Ph-negative B-cell ALL, historical 5-year survival around 20%. Now we're seeing at least double that, long-term survival rates 40 to 50% by reducing the chemotherapy but adding these very effective drugs into the frontline setting.
So describe a little bit more the dose-dense mini-CVD, because most of the trials have used blinatumomab in sequence. But what you're talking about is a regimen where you start the blinatumomab after the chemotherapy, so on day 5 for 14, 18 days. How much experience do you have with this kind of a regimen, what we would call the dose-dense mini-CVD, inotuzumab, blinatumomab?
Yeah, so we've done the dose-dense mini-CVD in Oblina regimen, really for at least the last 2 to 3 years, initially kind of in the relapsed refractory setting, which is still our go-to, particularly for salvage 1 patients, and then also moved it to the frontline setting for older patients. So data is still maturing, but the early data with this looks like it is maybe even better than the mini-CVD in Oblina when it was given sequentially. So just to back up a little bit, we initially would give 4 cycles of mini-CVD INO, and then follow that with 4 cycles of Blina. And then the question is, why are we waiting so long to give the blinatumomab? It's a very effective drug. It gets patients into deep MRD negativity faster. Why not give it earlier? And that's the development of this mini-CVD INO Blina regimen. And then now in the frontline setting, we've treated 20 to 30 patients, and the early data look like it is superior probably to the sequential way of giving it, probably because you get patients into a deeper remission faster, which we know is associated with better long-term outcomes.
So people did not want to use the Blina with the chemotherapy because they thought the chemotherapy will kill the T cells and therefore will reduce the efficacy of Blina. Have we seen that clinically or not?
So I think the same points were made with some of these TKI-Blina combinations. For example, there was some preclinical work to suggest that TKI, like ponatinib and blinatumomab, ponatinib may blunt the response to blinatumomab, but we see excellent response in that setting. It made sense that maybe that chemotherapy would blunt the T cell response to blinatumomab. I think it was a reasonable hypothesis, but we certainly don't see that. We see giving chemotherapy followed immediately by blinatumomab. We see excellent responses, deep MRD negativity in cycle 1, and early data suggesting better long-term outcomes than when it was given sequentially. So just the preclinical rationale, although it sounds very reasonable, just hasn't translated in the clinical data.
So you described positive results with the dose-dense mini-CVD in Oblina and salvage and in older ALL. When would you feel comfortable enough to move it to the younger patients to replace the intensive chemotherapy and the long-term maintenance? And how would you protect against a potential negative study that could harm patients?
I think it's a process, right? I mean, right now, if we have a patient that comes in right now who's 30 years old, we're still largely treating them with the intensive chemotherapy, like a full hyper-CVAD with inotuzumab and blinatumomab on our clinical trial. But I think with the data that we've seen, very low rates of relapse with the mini-CVD Inoblina regimen, particularly the dose dense, that we've started initially 60 years of age or older. I think it's a process to slowly bring that age down, evaluate it in patients maybe 50 years of age or older, 40, and then eventually I think that's how this regimen could be developed, where we could reduce chemotherapy even further for a younger population. How do we make sure that we're not harming patients? Obviously, we monitor these trials very carefully. We're always looking at relapse rates and making sure that we don't need any adjustments. But one way I think is the best way to monitor the efficacy of these novel regimens is looking at MRD, because we know that MRD correlates very strongly with risk of relapse and long-term survival. So what we see is really high rates of NGS MRD negativity after the mini-CVD Inoblina regimen, particularly the dose dense administration of it. So I think we're ready to slowly move it down the age group, monitoring very carefully, and maybe in the future, we've already reduced the chemotherapy with our full hyper-CVAD Inoblina from 8 cycles of chemo to 4. Maybe in the future, we'll be treating patients of in their 20s and 30s with low-dose chemotherapy Inoblina and still getting excellent results.
So what about the CAR T cells? So we always see that they work much better and they are safer at the time of minimal leukemia burden. Why are we still using them in relapse? When will the time come to use them as a consolidation in first remission? And what would be the potential objections to this kind of an approach?
So I think you're absolutely right that the best role of CAR T cells, or the best place for CAR T cells, is certainly in low burden disease. And I think what we've seen time and time again is that drugs that are very effective in the salvage setting should ideally be moved into the frontline setting. So I think the future really will be CAR T cell consolidation. Ideally, the patients, particularly for high-risk patients who otherwise might be referred for stem cell transplant. There's a number of clinical trials ongoing now investigating CAR T cell consolidation. We have a couple at MD Anderson with different CAR T cell products. I think we need to generate data before this becomes, quote unquote, standard of care, of course, but I think that it's certainly a very logical next step to evaluate, to treating these patients. Give them some amount of chemotherapy, Inoblina, get them into the deepest remission possible, and then consolidate them with CAR T cells, hopefully as a curative approach. It's the same thing we do now in first salvage. In first salvage, it used to be dogma that all patients who, if you could get a patient with ALL, relapsed refractory ALL into remission, it needed to be immediately followed by a stem cell transplant for them to have any hope of long-term remissions. Now we see that we can treat patients with mini-CVD Inoblina, particularly dose-dense mini-CVD Inoblina, particularly in first salvage, consolidate them with CAR T cells, and we see really durable remissions without the need for transplant, even in the salvage setting, I think, which argues even more to bringing that into the frontline setting.
Thank you, Dr. Short, for this very exciting interview. I think there are a lot of new things happening in acute lymphocytic leukemia, both older and younger, and we look forward to the evolution of the studies and their maturation so that we can hopefully change the standard of care in ALL soon in the future.